Good morning, good morning, good morning, you guys. Welcome back to another day in my life as a doctor. I am here on Thursday, June 4th. It is moving and moving and moving. We are a month away from July the 4th, which I don't really have plans for this. I don't know why I brought that up. But regardless, I just got to the hospital. I'm here for another consultation service. I have been on inpatient palliative care for the whole week now. And tomorrow I'm not actually going to be going in. So today will be my Friday, because tomorrow I have some employee screening for my new job that I'm going to be starting in a few weeks, or actually a few months, on September 1st. So I think the biggest thing I want to do today is that I want to see if I can try to pick up some consultations for some symptom management, maybe go see if I can help some patients with pain, for their cancer pain, and go from there. Maybe some other more unique symptom cases as well. So that's the goal for today. We have a family medicine second year resident that's on the team. So on Tuesday or a Monday when I first came, she was rotating with me. And then the following day, she just went with the attending. So maybe she'll rotate with me, maybe not, but regardless, we're gonna have a good day today. Yesterday, we had an amazing day with didactics and lectures. We talked about opioid use disorder and how to manage their pain. We talked about psychosocial components of palliative care. And then we also talked about hospice, specifically generalized inpatient care. And I learned a lot yesterday, and the fellows and I were kind of talking. It's kind of funny, the closer we got to the end of the year, the better the lectures were. So some of the feedback that we're gonna give our program is to try to move some of those lectures to the beginning of the year, because I feel like it would have been invaluable to learn those things way earlier in our training. So that's some of the things. Programs aren't perfect, and that's why we kind of rely on feedback. So we're gonna give that to them in the next coming weeks. How's yesterday?
Like nothing. And then the afternoon.
Ow. It's always the afternoon. We had some good lectures yesterday for our didactics. We talked about, we first started talking about like GIP for like hospice. Then we talked about psychosocial components of palliative care with Margaret. And then we ended off talking about pain management in those with opioid use disorder. And it was opioid use disorder, yeah. And it was addiction medicine. Well, he graduated, right? But he's like a EM, emergency medicine, and also addiction medicine. So he kind of gave like a different kind of lens of things, and how they use like methadone, buprenorphine, naltrexone. But I know we use like patches a lot for bup, but I guess like for those with opioid use disorder, like it's just not enough. And he kind of gave us some like references for like, say like a gram of like fentanyl on the street. It's like over 8,000 MMEs. So like the patch like barely even like touches it. Yeah. Yeah. Yeah.
It's far super old.
Yeah. Yeah, he showed us like a picture. Yeah, and that's like 12% purity of fentanyl that's like on the streets, which is like the small of the bag. And like, I guess fentanyl is like usually dosed like in micrograms, not like milligrams. So like that little small thing with 12% purity was like, actually it was actually closer to 9,000 MMEs. And usually the patches are like, for like reference, like we have like the 5, 10, and like 20 patches. And then usually if you have like, what was it? If it's like less than like 60 MMEs, you can do like a 5 microgram patch. And then the highest gets to like 180. So like trying to cover 9,000 MMEs with like a gram of fentanyl on the street, like the patches don't do anything.
What would you decide? And she said, I want to hear from each doctor what the answer is. How do you answer something like that?
I think there's like 2 ways to answer that question, because are they asking for the doctor's opinion on like what they would do personally, or like asking for a recommendation? Or is she also asking like, yeah, the recommendation versus like the doctor's personal opinion? And I think before I answer that question, I would probably like clarify that with them. Like say like, hey, like, you know, that's actually a really good question. Can you tell me why you're asking that? And then if it's more of like a recommendation, I would say like, okay, based off of what you've kind of shared with me about like your loved one and what they've like valued, like I would recommend this.
Which is exactly the right answer. He was kind of taking the lead in the meeting, which I kind of enjoyed. He said it almost exactly like that. But she's like, oh no. What I mean is, if it was your own family member, I want to know what you would do.
Mm-hmm.
And, but we did give it a glancing blow, kind of like you're saying, because look, there's so many different cultures, styles, and families that I'm just not going to answer it for my own personal family, but I can make a shared decision-making recommendation.
Yeah. Yeah, that's how, that, because I haven't had someone ask me in that way, like my personal opinion. Like it's always like more of like, they're kind of in a roundabout way trying to ask for a recommendation. But I feel like for that answer, I would say like, we all come from different backgrounds and value different things. So I feel that I can give you an answer, but my loved one isn't your loved one and they haven't been through the same experiences. So I'm not sure my answer would really be enough for you.
Yeah.
Yeah.
That's a nice thing to say, by the way. Because they didn't trust the medical system. They didn't trust any of the doctors. Finally, toward the end of the meeting, they were trusting everybody.
Because we had this lecture, and I also read like a fast facts on like medical mistrust.
Yeah.
And like I guess one thing, I don't know if we would do it in the family meeting. I feel like that's something maybe we'd find out like in our pre-screenings with them. But sometimes that's their first encounter is during a family meeting. But I guess like doing a little bit of investigation to kind of see why, to see like what kind of experiences have you had with like the medical system in the past that have led to you having medical mistrust.
Yeah. Hey,
Hey.
Just came to say hi.
Hey. Well, thank you so much. I appreciate. I'll let you know how the conversation goes.
All right, thanks a lot. Appreciate it.
All right. Bye.
Bye.
The 4 things I usually ask the oncologist is like, what is like the percentage of like response, like duration of response as well. What are the side effects from the actual treatments? And then the other thing as well is how long are they expected to be on it to like find some sort of like benefit from it. So oftentimes it's a risk benefit. Okay, we're doing this palliative chemotherapy. It's going well. I'm not getting too many side effects from it. But if they start getting a lot of side effects, like a lot of diarrhea, a lot of cytopenias, a lot of infections, peripheral neuropathy is a big one as well. That's pretty distressing for patients. It's like, when are the adverse effects from the actual treatments actually causing more issues than the actual cancer? And then we should think about like switching to like a more comfort-based approach or hospice approach. Yeah. But yeah. And then as a frame of reference for like when you have cancer patients in the future, when we think about like prognosis for cancer patients, the location of where the cancer spreads for metastatic cancers kind of makes a difference how long they usually have of life. For, say, if you have like lung cancer or if you have like liver cancer or whatever type of cancer, if it spreads to the bones, then that's not really like a huge impact in terms of length of survival. They can oftentimes live with that type of metastatic cancer to the bones for like years. It's just really uncomfortable and really painful. So people can, I've seen people with like, usually it's like prostate or breast cancer. If it goes to the bones, they can live for a long time with the treatments. And then for it's spreading to like, say, the lungs or like solid organs, like the lungs, the liver, the brain, the heart. So usually that's when they usually have like weeks to months. And the location of where it's spread really makes a difference. So just because someone says like, oh, they have metastatic cancer, like say like, okay, where's it spread to? And if it went to like solid organs or like the lymph nodes, then that's when we start thinking, okay, like they have like shorter time.
Dr. Guy told you that on the phone, right?
Yeah, he said that he thinks that she's been progressing and that there is another option for treatment, but that treatment, I forget the exact name, it's another immunotherapy, has worse side effects, and you have to have a pretty good functional status to use it, so he wouldn't recommend it.
Your boy?
Huh?
Your boy?
Yervoy?
That's the one after Keytruda.
Oh, yeah, okay. Yeah. Is there another name for it? Like a...
Yeah, there is a generic name.
Yeah, the generic name. I think he used the generic name, yeah.
Can you say the generic name for Keytruda?
Keytruda, Pembro.
Pembro.
Yeah.
That's half of it.
Yeah, pembrolizumab.
When we get in there in this kind of case, I would really like to find a paragraph like that.
Yeah.
You know, but what you find in your telephone conversation is I told them they don't remember.
Mm-hmm.
But it's this whole reinforcement cycle. You know, patients and families sometimes are reading the progress notes.
Yeah.
So if that's sitting there in the progress note, there's a natural reinforcement of that.
Yeah.
And then the other doctors can read that and reinforce it too. Oh, your oncologist has discussed that with you. I see that in the progress notes. So 2 out of 3, maybe even 4 out of 5 patients do want to hear about it. But we shy away from talking about it because 1 out of 5 patients says, oh no, I don't want to talk about it.
Yeah.
So we just kind of go on to talking about all the other things. But I think that's really good to bring it up. Because how are we going to make decisions, good solid decisions, without knowing the prognosis?
I asked them for permission, and that way, like, you know, I don't traumatize them like he was saying, but also if they don't want to know a prognosis, that's an opportunity to like explore why. Like, is there some sort of like unexplored anxiety or some sort of existential crisis going on that maybe one of our social workers can like meet with them and do an intake for? So like trying to like just keep digging deeper and deeper underneath to kind of see, okay, what's the reason why you don't want to know it?
I got some good cases for you. Sorry.
I know, yeah. So I try to tune this one as much as I can. That way, it's not like
that's super cool. You got them at 2 p.m. and I'm glad to follow up.
Yeah. Okay, so we are closing up shop pretty soon. I have a meeting at 4 and it's already 3:50 and I have to drive home to make it, so gonna be a little bit late, but regardless, today was a pretty good day. I just finished up a family meeting with a patient and their family members having a hospice discussion. I think one important thing that I wanted to share with you guys today is the importance of asking when a patient is okay or not to hear about a prognosis. And the reason why this is so important is because if you share a prognosis with the patient on how much time you think that they have left, it can be very traumatizing if they're not ready to hear that yet. So for example, I have been in clinic many times with my cancer patients, and a lot of times we have a general idea of how much time we think that they have based off of the nature of their disease, whether or not it's like end-stage cancer or not, whether or not they're having a lot of symptoms, whether or not their functionality is getting worse and worse and worse, such as going from walking and talking to more so bedbound for about more than 50% of the day. And we have classic signs that we see of when someone is getting closer and closer to dying. And if you share a prognosis with someone, it can be quite traumatizing if they're not ready to hear that. So for me, I always ask patients and their family members, do you want to hear our expected prognosis for yourself? And a lot of times if they say yes, okay, we can just tell them. However, if they say no, it's an opportunity to connect even deeper for the patient, because so many patients have different reasons as to why they don't want to hear a prognosis, whether it's fear, whether it's they have anxiety, so many different reasons. And my next question if someone says no is like, hey, can you tell me more about that? What are your hesitations about hearing a prognosis right now? And just because someone doesn't hear a prognosis doesn't preclude them from going into hospice. And that is an important question and an important point that I want to make for you guys. So always ask your patients if they are okay hearing a prognosis instead of just dumping on them. Because if you dump it on them, it's going to ruin your relationship with them and create a further divide with the patient-doctor relationship. So the biggest thing that you have with your patient is always going to be trust and listening to them. So just take a patient-centered approach. Ask them, what they're okay with hearing, what they're not okay with hearing it. And sometimes patients' family members will say no and the patient will say yes, which is a situation I ran into today. And that's ultimately, we have to go by what the patient wants. But if the patient's family member's in the room and they're saying no, don't just like say, oh, we're just gonna tell them anyways. Like, inquire with them, why don't you wanna hear a prognosis, or why don't you think they should hear a prognosis? And that will create even more trust with not only you and the patient, but also you, the patient, and the family members, because you guys are a team and you need to be able to act so. So I am going to head back to the office. I have about 8 minutes before this meeting. I might just do it virtually, but it was a pretty fulfilling day today. A lot of patients came in, a lot of hospice discussions, a lot of goals of care discussions, and not too much symptom management. Actually, I noticed that this whole week I didn't really have any symptom management cases, which is a little odd because this hospital tends to have a lot more symptom management, whether it's pain, agitation, nausea, vomiting, a lot of appetite discussions, whether or not someone is going to be doing artificial hydration or nutrition, which is a huge point of contention, especially for patients that have, what's up, boss? Dementia. What's up, man? So one of the things that you really want to do is just make sure you're having a full patient-centered approach. So one of these days I'm going to talk to you guys about doing feeding tubes and all of that in dementia patients, but today's not the day. It's always when you're about to leave and they're like, oh, we're coming right up. Which, yeah, honestly, it was perfect though, because I feel like having that meeting today after that long discussion on the phone, yeah, it helped. I think that was important because there wasn't much laughter going on in the room. It was very somber, you know, and I feel like a laugh here and there can really lighten the mood. Yeah, and I will see you guys on Monday. Yeah.
Have a great weekend.
Thank you, you too.
I'm surprised you call me after the I said, skirt off, nigga. Skirt up on nigga. Skirt down, you acting like we. Was it more than a summer fling? I said farewell. You took it well. Promise I won't cry. What's the milk? Give me a paper towel.
Tochi, it's my first time doing an event with you, so thank you so much for joining us.
Yeah.
I am the Associate Director for Partnership Engagement.
Mhm.
So I'm based out of Boston. I've been with the SU for about 6.5 years now, and I mainly recruited students from Boston. With tonight's session, we have two amazing panelists that will be joining us to share a little bit about their experience with us and their journey so far on their careers as doctors. So before we jump into that, I will bring on my great panelists who will be here and will be the shining stars of tonight's presentation. And now I will go to Dr. Tochi Nwaneri Nwosu. Please introduce yourself.
Yeah, nice to meet you guys. My name is Tochi Nwaneri Nwosu. I'm originally from Southern California in the West Covina Inland Empire region. I went to St. George's in 2017 and graduated in 2021. And I went to residency in Oakland, California at Highland Hospital for internal medicine and did a chief year and graduated. Got my license in 2024, and now I'm doing both internal medicine and hospice and palliative care.
Been there for 50 years. We're celebrating our 50 years this year, which is so exciting. Did you work as well? How was your process, Dr. Tochi, with applying for residency? I know it feels like forever ago now, but let us know a little bit how that process went for you.
Yeah, and before I left second year, they actually sent out a survey of like where we preferred to do rotations. And being that I was from California and I wanted to match in California, I put mostly California. And then when I got my actual like clinical like schedule, I got only one rotation, which was psych in Florida. And then the rest of them were all in California. And I actually ended up like taking a little bit more extra time to study for like step one. So like the schedule before that was like all California. So there, SU was very accommodating in getting me where I wanted. And during the actual clinical rotations, It was actually really good because not only did they have like a lot of like SGU attendings around that kind of like gave me a lot of like advice in terms of like how to actually manage residency and what the actual like curriculum was like. I feel like that was all pretty invaluable for me. So one of the things, so I know you mentioned the Department of Educational Services, DES. I know that they had tutoring services, and I know that they had like them in like kind of small group settings. So I remember I came in like already part of one, and we went to those like near pretty much weekly, and we met after like lab sessions, we met after lectures, and they would have like little PowerPoint lectures of like what was like the highest yield and things to kind of focus in on. And I actually didn't hear about Anki until med school as well, until like maybe the second semester. It was funny that as soon as you mentioned it, because I still use it to this day, I just brought it up. I just have it on my phone still. And I have like, and I would say that for anybody that is going into med school, I would say that like Anki is like a pretty well-established like method in terms of studying, because it goes off of the concept of spaced repetition. And with spaced repetition, it shows you a concept really quickly, and then after a while starts spacing it out from like a week to like a month to like a year. So like even now I'll still have like flashcards that I personally made in like residency that like I'll see like to this day. So like maybe I would have done it like a year and a half ago, and it comes up, and when I get it right, I'm like, okay, like this is actually working. And then kind of going based off what Carolina said in terms of like the step 1 and step 2 experience, like step 1 was I went to med school like right after college. So like I thought I was like, oh yeah, like it's college. Like I'm a biochem major with a chemistry emphasis. Like I'll understand these things. Even when I was in the class, I was like, oh yeah, this is fine. And like the pressure of actually taking it though, when you're in med school and like knowing how much is behind it, like it was like really different. So I met with my DES tutors as well, kind of went through like test taking strategies, and like I kind of had to like change my whole approach. And I think that's one of the things as well, is that you have to be comfortable being uncomfortable in med school, and be comfortable in changing a method like earlier rather than later, and not just sticking with something because it's worked for you in the past. So sometimes like my study habits change from like semester to semester based off of the content that I was seeing. And then I would also say that for step 1, I took like maybe like a couple extra weeks in terms of studying for it. But when I took the step 2, like we were saying, you have like those little shelf exams, which is like something you do after every rotation. Doing that at an actual proctored site, and for me, I did it at the same proctored site for almost all of them. So it was like, okay, I'm like familiar with the environment. And I think that's the big thing, is like the nerves of like walking into an 8-hour exam. And after doing multiple small exams, like and seeing like how the actual exam looks, like they pretty much all look the same. So by the time you take step 2, it's like you've already taken like 5 to 6 different shelf exams, which kind of like emulate that. So I did a lot better on step 2 as compared to step 1. And I think that's been like kind of like the natural trend for a lot of med students. But in terms of like study strategies, I got a lot of that from like DES, and then also the preparatory material was really good as well.
Yes, Dr. Tochi.
Yeah, I think that's the biggest thing. Like I feel like people, like yes, you're going to be very busy in med school, and like that should be the expectation, but that doesn't mean you won't have a life at all. And I think that first year or 2, you won't really realize that. But I feel like you do have that opportunity to like still live your life. I think also like going to Grenada and doing the med school there, like comparing my experience to like people that were like saying like, you know, Colorado or like other places in the US, like it was a much different experience. And I feel like, you know, it was kind of built in that there's like wellness at SGU just based off of the location.
I will go to Dr. Tochi next. Let us know, how was Grenada, because you were there. And you know, what clubs were you a part of, and what's like your favorite memory of Grenada?
Yeah, so I was there from 2017 to 2019, and I wasn't even really sure what I was expecting. I had a cousin that went there a few years before me, but I was part of the like SNMA club. I was part of both the volleyball and basketball leagues, did a little bit of soccer as well. And then I joined like I think it was like Bhangra, is like one of the dance clubs. So it was like a lot to do. There was like so many other clubs, and like just so many, like way more than I even like knew about. I would say you'd probably do yourself a disservice if you only go there and just stay on the school campus and just not really explore the island, because there's so much out there.
What is the one thing that you'd like to give as a piece of advice for the folks that have joined us tonight throughout that long journey of becoming a physician?
Yeah, I would say that the biggest thing that reflecting back on the entire journey of all these years of training, is take networking pretty seriously. I would say that for me, I started taking networking a lot more seriously in these last couple of years, and I've been going to conferences such as SNMA or like AMEC, things of that nature, and you'll be surprised the connections you make and how far people will go for you, just kind of being within that network and staying consistent with those connections. I made a lot of connections, which is what helped me for getting into this fellowship that I'm in for hospice and palliative care. When I go try to present at conferences, I know for me, I'm not really a big public speaker. I've been kind of putting myself in that position to try to do it more. But after doing presentations, people want to connect with you and work with you on projects, which will go a long way in terms of like interviews for the future. And a lot of the projects that I have been on recently, like people reach out to me either through LinkedIn or through email, and they want to jump on those projects with me and try to publish. So I'd say like really take seriously those networking opportunities and go out of your way to network and try to find mentors that are not only just local, but also mentors that might be in a different state. I even have mentors that are like in New York or in like Southern California that I like to talk to every so often, and like they kind of help me bounce off ideas, and like whether it's like looking for a hospitalist job or looking for a hospice and palliative care job, they will like go through my contract, or they'll talk about like, oh, like look out for this or look out for that, and like they will go out of the way to like try to help you. So try to like maintain those connections because they'll go a long way.
Thanks, Dr. Tochi. We appreciate you both and wish you the best of luck on you guys' journey, and look forward to seeing you.
Thank you for having me.
Thank you.
Thank you. Bye. Have a
Bye.
good night.
Have a good night. All right, so we are wrapping the day up today. I just recently finished a informational session for my medical school. I've been doing these for the last couple of years since I was in residency. I think I've been doing it for about 3 years now. And I try to just do a little giving back for my med school because I didn't really have anybody that was really a good source for me to kind of understand like what the med school process was like applying and what the things are to expect, how to study. So hearing about Anki or hearing about step 1 or step 2 and the licensing exams, that was actually all new information for me. So being able to go to these sessions and give people the lowdown of how it actually is actually very important. So that's like my way of kind of giving back to pre-meds and medical students alike. But despite all that, I'm gonna be wrapping up today. I think the biggest thing that I learned today is kind of what we talked about a little bit earlier about sharing prognoses and asking permission before doing so. So I would say I just want to reiterate that, doing that with your patients. And also, if you are a family member and you're not ready to hear about prognoses, then letting your doctors know that as well so they don't drop something traumatizing on you. But regardless, it was a good day in the life. Just drop by for the next video. I have a whole playlist of all these day in the life videos that you can check in the link down below. So I'll see you guys later. Like the video if you haven't already. Peace and have a nice day.